Hello everybody, it's dinner time. You are still here. Thank you very much for being here together with us. When I saw my slots, I saw that it's 7 p.m. last day. I think we will be speaking this presentation over a beer, a pint of beer. I have discussed this a lot recently. This will be a presentation for 15 minutes. It's discussed a lot. I would like to take your opinions as well. Is it right to start medication to risk group people before disease? First, the first-time psychosis have been used, but nowadays antidepressants are coming more to fore, and there are very interesting results with this regard. Patrick McCorry says that actually we should give the name of Professor Patrick McCorry if we are speaking about risk group. In 2010 he became the Man of Year, honor first time given to a psychiatrist, and he began to manage a high level of funds in Australia, in Canada as well, I think in Europe, in England. There is a health policy for risk group patients. Actually not patients but individuals, candidates, patients, let's say them. They are following closely. Actually we have planned something and we gave to Tubitech project, but still no echo. What are we speaking about? There are very psychotic like living, subclinic livings, sometimes hearing voices or thinking of mystic things, or being suspicious about, for example, whether somebody is speaking about me and calling me a gay. This is a group which is having this sort of psychosis-like experiences. It's shown to be around 17.5%. We made a study, me, Tolga, we determined as 7% and 3% in Izmir, in Western Turkey. Some of them are coming as psychotics to the clinical environment. What is creating this transition, and can we prevent this? After schizophrenia arose, it's hard to treat it, but maybe we can prevent it with some therapies before schizophrenia arose. Is it possible to have a better prognosis of schizophrenia? This is the question. Psychos-like experiences or psychotic experiences of the people in risk groups are not always causing psychosis. This perception about it always does is actually wrong according to certain studies. This is Turk SCH study. We have done the second of them. The first one had been published. We followed in Turkish CH population. We evaluated the people having psychos-like experiences, and we found only a 3% transition to schizophrenia. Affective disorders around 47%. Psychosis group is only 5%. The bigger group has developed depression or anxiety disorder. So we cannot say that people in psychosis group will become schizophrenic in the future. This perception should be discussed. They are developing as psychological disorder, but mostly anxiety disorders and depression. That's why maybe some antidepressants have an effect on psychosis risk group people. This is a North America Proton study. The previous treatments of the high-risk group had been evaluated. You see the psychosocial therapies here. The candidate individuals, candidate patients, nearly 55% of them are having any psychotherapy, and their psychotherapy frequency throughout their life is 80%. When we look at the pharmacological treatment, nearly half of the patients are taking any psychopharmacologics, 36% antidepressants and 12% antipsychotics. lifetime psychiatric medication probability is 60%, antidepressant around 50%, antipsychotics around 23%. Thinking from clinical perspective, if you examined people who have suspicions but you couldn't call them psychotic, you should care them closely and you can start a low level of antipsychotic. Sarah's told this very nice. There are many basic works including diagnosis criteria. They have three main themes. One is very vague psychotic symptoms. It's about the violence. For example, patient says that people possibly calling me gay, but I'm not really sure that. So it should be slightly or vaguely and distinctly. Also, it should be short. If it's getting more severe, yes, I am followed, but it just goes less than 1 week. And that third possibility is to have a psychosis or schizophrenia history in the family or another schizophrenic personality disorder. If we can follow these people only for 1 year without any treatment, their psychosis transition is around 36%. It's an important study made by McCor and his team in 2002. They have been given risperidone for 6 months, controlled double-blind work, and after 6 months they follow it for 1 year, and they monitor it up to 2nd and 10th year. You see the first 6 months. This is post-treatment. No medication is given here, but if, according to the needs of the patients, a psychotherapeutic approach is adopted here. You see the passing to psychosis 35%. Even if you don't touch them, they are developing 35%. What happens in treatment? In the first 6 months is 9.7%, and after in the post-treatment it becomes 20%. There is a sub-analysis 9.7 in the patient group or individual group with therapy continuation. It decreases to 50%. So adherence to therapy has an effect to this. But what's important, doses for risperidone is around 1 to 2 milligram, but side effect risk is quite high, especially young individuals. In 2nd year, this goes to 20%, and in 10th year it becomes 35%. Another study, by adding cognitive behavioral therapies, can be changed this, or if we only implement CBT to these patients, what happens to their psychosis transition? Risperidone plus CBT transition rate is around 5%. If only CBT, it's 9%. If supportive treatment, it's 7%. And need-based treatment is around 5%. Figures are so close to each other. When we compare it with McCorry's study, we can say very comfortably that in any therapeutical intervention can prevent psychosis transition. In Dolan-Depin also, in psychosis transition ratio, there is a marked increase, and medication group has less statistically, but has a marked decrease, and in average 10 milligram olanzapine, and weight gain is quite marked in young individual. There is another risk group works on AMI. It's very effective, and there are side effects. Iprezol also have been tried, especially for candidate risk group people. There were improvement in prodrome symptoms, but the main target was the improvement of cognitive functions. This couldn't be found, but it's quite sensitive with regards to side effects. Yes, antipsychotics are preventing transition to psychosis, but there is a high level of side effects in young individuals. This is work which is surprising us. Antipsychotics might not be always effective. Even their effect can be discussed. But what about the other groups of medication? Here, especially antidepressive and antipsychotic drugs had been compared in this group, and both groups, when their demographical data had been compared, there is not a great difference, generally similar features, but with regards to conceptual disorganization, in antidepressive group, there is a prominent difference. In the patients with second-line antipsychotic, the conceptual disorganization scores are higher. There is such a difference in two groups. But the result is very interesting. In 8 weeks of treatment, in antidepressive group, no patient had passed to psychosis, had started or developed psychosis. So it prevents. Antipsychotic groups, 12 people in antipsychotic groups passed to psychotic picture. There was just one main difference, conceptual differentiation. Can it cause such a result? Open to debate. But from this, we can say that in this group, candidates, antidepressants have a role of decreasing psychosis transition. Maybe it's not only related to psychosis development, but in an important part of these patients, they have a potential of developing psychosis or other psychotic problems. These should be studied. We don't know them very well. This is a recent study related to antidepressive medication. In this study, antidepressants and antipsychotic treatments had been evaluated with regards to their effect on cognitive function performance. These are normal individuals. In beginning and after 6 months, when the response to continuous performance test has an improvement in 6 months, in young people we see an improvement very openly. Here, these are offs, those who never took a treatment, their cognitive function development in 6 months. And those who are taking antidepressants, we see a similar improvement. But what's interesting is in the candidates candidate patients having antipsychotics has a decreasing curve of cognitive function. When we look at California learning test, also we see that the individuals having antipsychotics had worsened their cognitive functions, but those who received antidepressants, especially in verbal memory, there is an amelioration approaching to normal. Another interesting study, 6 years of follow-up with antidepressants and antipsychotics. Also psychotherapeutic treatment had been looked, and psychosis development ratio had been evaluated. If you look at this, CBT and antipsychotic groups are the worst groups. Is the worst group CBT plus antipsychotic? And CBT plus antidepressants is the best group. Only CBT group is also better than the antipsychotic group. So antipsychotics features of helping the antipsychotics effectiveness should be also discussed according to this. Another issue, omega-3 studies and research had developed very interesting results. Generally 1.5 days, 12 weeks of omega-3 usage. In 12 weeks, in 1 year follow-up and 6 to 7 years, an important difference had been organized. Patrick McCora changed this in 6 months. They didn't find any difference. And then 12 months and 1 year had been published and no big difference had been found. So omega-3 is not suggested a lot, but still I suggest omega-3 in these people. But so far it's not an evidence-based suggestion. And we looked also glutamatergic system and we looked their role related to candidates. Glycine is a treatment which is studied. Some case presentations had been done. In certain cases, there is a significant decrease in symptoms, but in some other cases, no change had been observed.
And this is a case of mine, and I'll talk about this in the last place. It's a young student who qualified for university, but he chose not to go to university, stayed home, spent time home. When the family asked their son what happened, he said people call him homosexual when he's walking around on the street, and he was scared that people would call him that at school, but his belief in this ideation was not very strong, and its severity was low, and it got strong at times, and he said he heard some sounds too, but the sounds were not continuous and not very severe. I monitored the patient for 1 year. I did psychotherapy slowly. He started going to university. His relationships got better and treatment ended. But about 2 years later, I got a call from the mother telling her son got a psychotic exacerbation and stopped medications and refused to come to the doctor. In conclusion, the outlook does not always turn to psychosis, and there is a higher probability of emergence of depression and anxiety symptoms, and we have a study, and we are receiving new data, but drug therapy is controversial, and it's not clear whether it has efficacy, and dosage and time is not clear, and there is a high risk for side effects. Psychotherapies, especially cognitive behavioral therapy, has a good outcome with high evidence score, and drug plus CBT seems effective, but we need to work on the basis of evidence. Thank you very much.